Thank you, Mr. Chairman. First, I would like to thank Professor Marcelin for kindly inviting me. It's an honor to speak here. These are my disclosures. This is the icteric eye of one of my patients, a 31-year-old woman who came after she had developed jaundice 2 months before and increasing pruritus. The detailed history taking of this patient revealed that there were no serious diseases in the past. She was on anti-conceptive medication for a decade without any side effects. And she had had treatment for an urinary tract infection 3 months before. In her lab, I will not show it, she had marked elevation of conjugated bilirubin, as you could see, and also elevated alkaline phosphatase, fulfilling that criteria for cholestasis of the EASL guidelines. Physical examination did not reveal any further findings than jaundice and serum liver tests I mentioned. The next step was ultrasound. She didn't show any signs of dilated ducts. She did not have gallstones or a tumor possibly explaining the jaundice. It was a young woman, we tested for anti-mitochondrial antibodies as recommended, and the PBC-specific ANA, anti-nuclear antibodies, the SP100 and the GP210. And I want to start with my discussion of management of cholestatic diseases with primary biliary cholangitis. The name change has been initiated by Professor Poupon from Paris in 2013-14, and we finally succeeded to do this because today more than half of the patients with PBC do not develop cirrhosis anymore. And this was a burden for the patients and an initiative of the patients to change the name. You know the criteria. Most of them are women. Mean age at diagnosis 40 to 60. Former survival without treatment was 7.5 to 16 years without transplantation. And alkaline phosphatase and gamma GT elevations are typical, and together with anti-mitochondrial antibody positivity, we make the diagnosis today. Sorry for that. The key symptoms of the patients are fatigue and pruritus, which may burden up to 80% of the patients. This is our view 20 years ago, very simple. We thought it's an immune-mediated bile duct injury, and hydrophobic bile acids may aggravate the damage, and cholestasis with the retention of hydrophobic bile acids may finally lead to fibrosis and cirrhosis and liver failure after a period of 10 to 15 years without treatment. And we thought about genetic predisposition, environmental factors, and a complex cellular humoral immune response in these patients leading to the disease. But already in the 1990s, and I want to talk about the possible pathophysiology because to better understand the therapeutic strategies which are now developed. Already in the 1990s, the Spanish group of Dr. Prieto had the observation that these patients probably do not produce enough bicarbonate in their biliary tree. And this has now been substantiated by very nice papers, as mentioned here, the last one, a short time ago in Hepatology 2018 by Dr. Banales, one of the former co-workers of Dr. Prieto. But what does it mean that there is not enough bicarbonate? We have been thinking about this a long time, and we developed the biliary bicarbonate umbrella hypothesis. And here you see a cholangiocyte, and on its apical side towards the bile, you have maybe I have an arrow here, yeah. You have a couple of transporters and channels, the AE2 anion exchanger 2, which exchanges bicarbonate with chloride, and 2 chloride channels. And these 3 together are responsible for secretion of bicarbonate from the cholangiocyte. And we think that this bicarbonate umbrella above the membrane of the cholangiocyte protects the cholangiocytes against uncontrolled invasion of bile acids. Hydrophobic bile acids and glycoquinodeoxycholic acid is the major hydrophobic bile acid in human. And when it's protonated, it can invade the cell without help of a transporter, what we showed. So the bicarbonate umbrella keeps the bile acids as bile salts with a negatively loaded state. But if this doesn't work, and we show that experimentally, then glycoquinodeoxycholic invades cells and induces apoptosis and or senescence in the cholangiocyte, leading to death of the cells. In PBC, the Spanish group and the Yale group found out that first, there is an upregulation of microRNA 506, and I'll leave it there. This is a little bit unstable. microRNA 506, which interestingly downregulates the anion exchanger 2, and it also, this shown by the Yale group, downregulates the inositol trisphosphate receptor 3, which is crucial for insertion of all these proteins into the apical membrane. So we have a secretory defect in the cholangiocytes of PBC patients. Interestingly also, the aberrant expression of the pyruvate dehydrogenase complex subunit E2, which is the target of T cells in PBC portal fields, and also the target of the anti-mitochondrial antibodies, is aberrantly expressed secondary to the damage induced by glycoquinodeoxycholic acid. In addition, it may not only be PBC, but also other fibrosing cholangiopathies, which may have a defect of the biliary bicarbonate umbrella, cystic fibrosis, associated liver disease, in PHC possibly, and possibly also after transplantation, because the stimulation of the muscarinic receptor type 3 does not work in the denervated liver. So there is lots of space for further speculation on pathophysiology of fibrosing cholangiopathies. In PBC, we now, some of us, and this number is increasing, think that maybe the defect of the biliary bicarbonate umbrella is first and the immunologic bile duct injury is second. Ursodeoxycholic acid has been introduced more than 20 years ago. In the 80s, the first papers from Leuschner and Professor Poupon from Paris came out, and the Paris group has done a lot to establish urso treatment. We know today that every single patient with PBC should have ursodeoxycholic acid at the recommended dose as given here. And only in end-stage liver disease, liver transplantation is the treatment of choice. How does URSO work according to our thoughts today? We think that the major mechanisms are the stimulation of hepatocellular and of cholangiocellular secretion, and also anti-apoptotic effects and reduction of bile toxicity have been described, but on the left side, these are, in our view, the major mechanisms. And this is a group of people who spent many years on this subject. And maybe the biliary bicarbonate umbrella is also crucial for this. We know already for a while, I myself spent 15 years on this slide, that ursodeoxycholic acid conjugates act as post-transcriptional secretagogues, and they are potent signaling molecules at low micromolar concentrations, thus physiological concentrations in hepatocytes and probably also in cholangiocytes. So, and they insert transporters, key transporters like the bile salt export pump or the bilirubin transporter, the MRP2, into the apical membrane. And this is defective in a cholestatic hepatocyte, what we showed also experimentally. Now, we know today that 2 of 3 patients with PBC are effectively treated with ursodeoxycholic acid and have a normal life expectancy. But the third of the 3 patients does need a secondary treatment in addition to ursodeoxycholic acid. How can we determine which PBC patients can be treated with urso alone and which PBC patient will need an additional secondary treatment? There have been several scores developed, the Barcelona score, the Paris 1, Paris 2 score, the Rotterdam score, for example. And, but the best at this moment appears to be because it includes most patients, the largest cohort, more than 4,000 patients, seems to be the PBC Globe score, where 10 large centers accumulated their data and made calculations for the prognosis of the patients. And when this Globe score, which includes age, bilirubin, alkaline phosphatase, albumin, and platelets, when this Globe score is below 0.3, then these patients have an excellent prognosis, long-term prognosis, identical to the normal population. But when it's above 0.3, then you see the difference in survival with the normal population. And these patients are those who will need secondary treatment. How far are we with secondary treatments? You will know the first drug accepted provisionally by the FDA and the EMA is the FXR agonist obeticholic acid. That's a New England paper from 2016, and it showed that surrogate markers of prognosis improved in patients treated with urso plus FXR agonist obeticholic acid in comparison to urso alone. How does this work? We know the farnesoid X receptor, it's a nuclear receptor, and it protects against toxic effects of hydrophobic bile acids in the hepatocyte, but also in other cells. It's also found in cholangiocytes and in intestinal cells, for example. And it downregulates the uptake mechanisms for bile acids, like the NTCP, but also OATPs, and it also downregulates bile acid synthesis in hepatocytes. But not only that, it also stimulates secretory mechanisms by upregulating secretory pumps, both at the apical membrane and at the basolateral membrane. And it also stimulates the metabolization of bile acids. So obeticholic acid is a potentially potent target. Interestingly, in animal models of the Trauner group from Vienna, bicarbonate secretion, stimulation of bicarbonate secretion was the key mechanism, key protective mechanism of an FXR agonist. The second one, the PPAR agonist bezafibrate, we had a lot of data from Japan in small studies which indicated that urso plus bezafibrate is more effective in cholestatic disease than ursodeoxycholic acid alone. And this is the really beautiful study from the French group, from the Paris group, Dr. Corpechot, Chazouillière, and Poupon and colleagues, which clearly show that bezafibrate not only improves serum liver tests, it also improves fibrosis and prognostic markers of progression of the disease. So clearly this is a drug for the future. And the European clinical practice guidelines, so far we wrote them in 2017 or published them in 2017. We recommended obeticholic acid as a secondary treatment. And now we will give an update not far from now for bezafibrate, which is now published. Possibly the mechanism of action not yet really clear, anti-inflammatory, NF-kappa-B inhibition, but also phospholipid secretion into bile, which is phospholipids are a protective factor in bile against hydrophobic bile acids, where they form micelles with the hydrophobic bile acids. These are discussed mechanisms. The third one is budesonide. It was a complicated trial. I only mentioned it. It was shown at the ILC earlier in 2018. Interestingly, it did not reach the primary endpoint, histological criteria, but it reached the POISE criteria by which obeticholic acid was accepted by the authorities. So this will have to be discussed, whether there is a difference in the efficacy of obeticholic acid and budesonide. will have to be done as soon as the paper comes out. One point to pruritus for the clinical management. Our patients, 70%, may develop pruritus with PBC during the disease course. We still do not completely know the mechanism of pruritus. We know that when the enterohepatic circulation, here shown in green, is interrupted at the level of the hepatocyte or at the level of the cholangiocytes, pruritus can develop. And pruritogens, they accumulate in the systemic circulation. This is all based on clinical and experimental data. They accumulate in the systemic circulation. They are probably biotransformed or formed in the liver and or gut, and they are secreted into bile, and they affect the endogenous serotonergic and opioidergic system. We know this because some drugs which have been developed act at these levels. Today, we think that a critical role for the development of pruritus is for autotaxin and its product, lysophosphatidic acid, which is a pruritogen and has receptors on pruritus nerve endings. But this is not enough. It's well shown, or we have shown that autotaxin correlates with the severity of pruritus. It's the only molecule in blood which has been shown to correlate with intensity of pruritus, not bile acids. The other one is factor X in the bile, and we do not yet know what is factor X. When we do nasobiliary drainage in our patients, which is strictly experimental, then the pruritus disappears. Severe pruritus disappears within 12 to 24 hours in most of the patients. This is very impressive. This is our strategy: cholestyramine, rifampicin, naltrexone, sertraline are guideline recommended treatment strategies. And the possibly new findings, we started 3 years ago, the FITCH trial, fibrates in itch, and the Corpes-Shaw group in 2018 reported that PBC patients had improvement in itch. We study it in fibrosing cholangiopathies, also in other diseases, and we will finish the trial early this year. Another possible benefit, ASBT inhibitors, which inhibit bile acid uptake, but possibly also uptake of other factors into the enterohepatic circulation. Though we will have to wait for more data. Our patient was negative for the AMA. The next step would be cholangiography, and today it's MRCP, magnetic resonance cholangiopancreatography, to show or to exclude primary or secondary sclerosing cholangitis. This is the typical patient in the Netherlands with primary sclerosing cholangitis. Please note, 2/3 are male, 2/3 have an inflammatory bowel disease. In the Netherlands, we treat our patients in above 90% with URSO, and the liver transplantation-free survival is 21 years. This is the best worldwide, but also in France, the liver transplant-free survival is about 17 years. I think these two countries have the best statistics regarding survival. URSO, never shown, but there is also no trial which has the length, the adequate dose, and the number of patients included to be able to say anything on prognosis. We only see that it has anti-cholestatic effects in PHC, and it has almost no side effects. And liver transplantation is the only effective therapy. Endoscopic treatment of stenosis, 2018, Ponsiun and colleagues' DIL-STENT study clearly showed that balloon dilatation has to be preferred versus stenting. Both are equally effective, but side effects were the 6 times higher serious side effects in the stenting group. So endoscopic balloon dilatation. Future therapy, vedolizumab, an alpha-4 beta-7 integrin antagonist. For me, question marks. There are mixed first results. URSO, shown in the phase 2 trial, it's anti-cholestatic, not as strong as URSO, but it may, in combination with URSO, now in a phase 3 trial, maybe we will have an additional benefit. Nuclear receptor agonists, PPA agonists, studied in Paris again, and the FGF19 homolog, NGM2, FXR19 homolog, NGM282, was just published in Hepatology, where we saw improvement of fibrosis markers during a 90-day treatment period. There will also come a phase 3 trial in the future. So there's something's happening, although we still don't understand the pathophysiology of PSC. When you look at PSC, you always have to keep in mind, and we probably didn't do that enough, that there are many alternative diagnoses which also cause a cholangiographic and or histologic feature of sclerosing cholangitis, and they are all taken up on the right side. And I only want to mention shortly IgG4 disease, because 15 years ago we didn't know IgG4 disease. It was defined in 2007. IgG4-associated cholangitis is mainly a male disease. Middle-aged and elderly males above 50, more above 60 are affected. Jaundice, weight loss, and abdominal pain are the major symptoms. Localized organ swelling, as you can see here in the pancreas of this patient with autoimmune pancreatitis, can be observed, and you see the cholangiogram. Or other organ manifestations, interestingly, often glands which produce bicarbonate. The consensus criteria on histology, lymphoplasmacytic infiltrate, storiform fibrosis, obliterative phlebitis. And you have to have IgG4 positive plasma cells in the resection specimens or in the biopsies. The serum IgG4 is unfortunately cannot select between IgG4-related disease in PSC and cholangiocarcinoma. In part of the patients, there is overlap when the levels are only a little bit enhanced. So this is not an ideal marker of the disease, and we were able to show by characterization of B-cell receptor clones that B-cell receptor clones in IgG4 disease are ranked higher than in healthy controls. We usually have the first clone with IgG4 positive clone among all IgGs in number 100, and these patients have it very highly expressed. And after corticosteroid treatment for 4 weeks, these clones have completely disappeared. And when you look at a larger cohort, then you have, for this test with next generation sequencing, a sensitivity and specificity of 100% between IgG4 disease and PSC and cholangiocarcinoma. But nobody can pay that, and this is enormous workload. So one of our fellows developed a simple PCR for IgG4, and the area under the curve reached a 0.99 to differentiate IgG4-related disease from PSC and cholangiocarcinoma. And in our hospital, it's now established, and we use it for all our patients where we don't know the diagnosis. One last hint for IgG4 disease. We found out in our cohort, now we have about 90 patients, and about 3 or 4 patients have long-term exposure to solvents, to paints. They are into diesel, for example, and we think occupational factors play a major role in the development of IgG4 disease, and this would explain the high prevalence in male patients, because these professions are mainly male. Treatment is prednisolone. In the Netherlands, we use lower levels of prednisolone than in other countries. These are the official guidelines. And more, we tend to do long-term maintenance treatment. I'm above my time, but I want very shortly, where this was negative in our patient, a liver biopsy was performed, which did not give any more hints in our patient. And then you can decide then to do genetic analysis for cholestatic syndromes of unknown origin. We did that, but also in our patient, this was negative. Here you see the mutations we know today, consequences of transporter defects. I only want to come, the best studied is the MDR3 deficiency or ABCB4 deficiency. But I want to come to the last PHSF, persistent hepatocellular secretory failure. We saw a series of patients, and we published the first 13, who had all serum bilirubin levels above 255, persistently elevated bilirubin in this patient, almost 8 weeks. And the underlying cause, we thought it was the antibiotic clavulanic acid. When you stop it, usually it becomes better, but in some patients it's progressive icteric disease. Exclusion of bile duct obstruction by imaging, no underlying liver disease, very important. And I added a rapid response to rifampicin. Here you see the 13 patients after rifampicin, after 1 to 2 weeks, dramatic improvement in patients who were also already given up by other institutions. So this is a very rare manifestation of a disease, and we found in some of them also mutations in the transporters, but this has to be studied in more detail. There I'm at my end, sorry for the delay. This is a summary of the management of cholestatic liver diseases in 2019. Thank you for your attention.